So here we are, starting to remove the cataract on this 63-year-old gentleman. He's had prior LASIK surgery in 1999, and at this point we have created his primary incision, astigmatic incision, initial lens fragmentation, and capsulorhexis with the femtosecond laser. The mission plan is to remove the cataract and place a symphony lens implant to enable him to see far and near with minimal use of glasses. As a side note, I've known this patient for the past 22 years. This case involved using a combination of surgical and personal skills that have been developed over a lifetime. After this case was completed, I realized how many things could have gone wrong, but didn't because of the life lessons that were applied throughout the procedure. We'll highlight these teachable moments over the next 24 minutes. We're about 50 seconds into the procedure and everything is routine, but watch what happens at the 59-second mark. There's a sudden, unusual response to the patient's hydrodissection. I know something is different, but I can't visualize exactly what is different. So we gently rotate the nucleus, and it rotates just a little bit, and that looks about right. And we're going to center up the microscope and introduce the phaco handpiece. Lesson number 1. Early identification of a problem is key. Learn pattern recognition. We know what normal is after having performed cataract surgery tens of thousands of times. We have identified early that something is not normal. So we stop, relax, assess the situation, then move forward with an alternative plan. If we forge ahead in our usual fashion, hoping that everything will work out, then we are living in denial. Admit to yourself early on that something is not right, then make adjustments. Here we're trying to rotate the nucleus, and it rotates with resistance, which is not normal. The lens, while being rotated, seems to move in an unusual manner. For example, the lens seems to move unusually far to the left. So here we are thinking, okay, the lens is not moving quite right as we rotate it. Let's try and get this heminucleus divided into quadrants. But as I'm doing that, I'm thinking something's not right. So we, again, pause, consider our next steps, and what we decide to do is infuse viscoelastic into the anterior chamber to stabilize and deepen the anterior chamber, and then we can rotate the nucleus in a more controlled manner under viscoelastic. So the viscoelastic deepens the anterior chamber, it stabilizes the cataract, and allows us to proceed in a more controlled manner. We could forge ahead with the phaco tip and the second instrument to rotate, but somehow that seemed to be a little stressful on the nucleus and on the nucleus and bag complex. If we infuse the eye with viscoelastic, it will allow us to move the nucleus without placing unnecessary stress on the zonules or the capsular bag complex. Here is our chopper, and we're just trying to rotate the nucleus another 90 degrees with the aid of viscoelastic to stabilize the anterior chamber of the eye. It's rotating well. So now we've rotated another 3 clock hours, and that looks pretty good. So we're going to go ahead and reintroduce our phaco handpiece, and then we begin to emulsify and break the nucleus into 2 halves. And we're trying to rotate this half another 3 clock hours and break the half on the right into quadrants. We're able to break that half into quadrants, and so we then begin to bring this first quadrant into the phaco tip and emulsify it. We know we have extra viscoelastic in the anterior chamber to stabilize the eye. Then we take the quadrant on the left and begin to emulsify it. We go slowly because we're not 100% sure that the capsular bag is normal. We don't yet see any abnormality in the bag, but somehow the way the nucleus is behaving in the eye is not normal, so we suspect indirectly that there might be a capsular issue. We decide to infuse more viscoelastic into the anterior chamber to protect the cornea and to bring this nucleus anterior to the capsular bag. We can notice that there's an unusually clear red reflex at the 6 o'clock position. And so we think there might be a capsular opening at this point because we can visualize that unusually clear red reflex. That's not a good sign. We use more viscoelastic to bring the nucleus into the anterior chamber, anterior to the anterior capsule. Which brings us to lesson number 2. Luck is where preparation meets opportunity. Because we now have identified the unusually clear red reflex, which 99% of the time indicates an open posterior capsule, we need to take measures to, number 1, keep the cataract from falling back into the vitreous, and number 2, remove the remainder of the cataract safely so we don't have to refer this patient to our retina colleagues for a vitrectomy to remove lens fragments in the vitreous. So we have viscoelastic behind this nuclear fragment and in front of the nuclear fragment, and we elect to use our phaco handpiece to remove the remainder of this cataract. We're going to use a cyclodialysis spatula to support the nucleus from behind to prevent it from moving posteriorly into the vitreous. So we're on the higher vacuum setting with the phaco handpiece, and we emulsify the remaining half of this cataract. We're supporting the nucleus from behind. There's viscoelastic support from behind the nucleus as well. The nucleus is being removed in a controlled manner. None of the fragments appear to be moving posteriorly. Everything is flowing nicely into the phaco handpiece. We're looking good. We've got the entire nucleus out at this point. We're going to stabilize the anterior chamber with more viscoelastic before we remove our phaco handpiece. Now we're out of the eye. We're going to infuse even more viscoelastic to identify what's going on. And then we see this very clear red reflex, which is not a great sign. So now we realize what exactly happened at the 59-second mark. During hydrodissection, there was an anterior capsule extension which migrated posteriorly and extended along the posterior capsule. We have a posterior capsule opening that extends from 9 o'clock down to 4 o'clock. So we want to place more viscoelastic and expand the capsular bag and get a clear understanding of what we're dealing with now. How are we going to remove the remaining cortex? We can use a vitrector. We can use irrigation and aspiration. Those all involve infusion of fluid and some degree of trampolining of the anterior chamber of the eye and turbulence in the eye. So we elect to use our viscoelastic cannula and perform what I call a dry irrigation and aspiration to remove the cortex. I'm infusing generous amounts of viscoelastic into the capsular bag to keep it expanded. And then I use the same viscoelastic cannula to aspirate the remaining cortex in a super controlled manner from the capsular bag. In my mind, in this particular circumstance, I have the greatest amount of control by removing the cortex in this manner. Irrigation and aspiration would remove it, but there would be turbulence which might cause some of the cortex to move posteriorly. It might bring vitreous into the anterior chamber. Anterior vitrectomy using irrigation, aspiration, cut settings might create the same types of complications that irrigation and aspiration alone might create. So we're using generous amounts of viscoelastic, but it ends up working very nicely, and we end up being able to remove all of the cortex in a very safe and controlled manner without putting undue stress or stretch on the capsular bag, because we do not want to extend the capsular opening. We want to preserve the capsular bag complex that we currently have and not make it worse. But at the same time, we want to make sure we can remove the cortex in its entirety, which we're able to do using this technique. So this brings us to lesson number 3. Adversity does not build character, it reveals character. When there is chaos, effective leadership involves controlling your emotions, maintaining your composure, and moving forward carefully and methodically. Everyone is watching how you respond every moment in a leadership position. If I act nervous or anxious or uneasy, the operating room team and the patient will notice, and the situation will start to go sideways. Currently, this is patient number 8 of 13 for the afternoon. We are already 1 hour behind our schedule. Outside of the operating room, our nursing team is busy keeping our patients that are waiting for surgery occupied. Inside the operating room, this 10-minute surgery is now at the 20-minute mark and may last 30 minutes longer than anticipated, throwing our schedule further behind. The surgeon's primary responsibility is to finish the mission successfully while keeping the patient and the team relaxed and confident. There's a YouTube video with Jocko Willink, a retired Navy SEAL, who describes it so well on his video, Mental Exercises to Overcome Stress.
Mental exercises to learn to control one's pulse and breathing in really stressful situations or when very nervous. What do you do? One thing that I know I do, and this is I guess it may be considered a technique, but it's like the technique creates the solution. Let me explain this to you. One of the things that I do in stressful situations, there's something that I always try and do, and that is no matter what's going on, I try and remain calm in my voice. Ooh, so when things are going crazy, I try and get on the radio and say, hey, we need 2 more people over here. Not, hey, we need 2 more people over here.
Roger that.
So if you're going to talk in a calm, controlled voice, then you can't be breathing hard. You can't be excited. You can't get angry. You can't get frustrated. You have to lock all that up and get it under control before you open your lips.
Right.
And start saying something. And so I'm always very focused on I am going to sound calm, cool, and collected when I open my mouth. That way, and in doing that, the only way to make that happen is to do everything we just talked about. Control your breathing, control your pulse, control your emotions, get all those things under control, and then say, all right, we need 2 more guys down here immediately, now. And everybody goes, oh, okay, let's make this happen.
And coming from you especially, in your case, you're the boss. So if you're calm, cool, and collected, that translates to your troopers.
It absolutely
Right.
does.
So it would for us as well when we were doing Overwatch, 6 is 6'3", movement to your left.
Where are they at? No,
your left.
Right. Think about what happens when you do that.
So imagine if I went, holy shit, 6, they're on your left, they're on your left.
Right. I'm freaking out.
It would be lost. But you're that voice because snipers are Overwatch. The troops feel better when they know, okay, the snipers doing Overwatch. Okay, we're gonna be okay.
We're gonna be all
So
right.
if I got on the radio and talked the same way, so nope, okay, yeah, adjust fire 400 meters north, fire for effect, Roger that. That's a good point. I never even thought of that.
Yeah.
I think airline pilots train that too,
they-
because when you hit the turbulence, and they're hey guys, sorry about that turbulence.
Yeah.
Just go ahead and put your seatbelt
And
back on
Yeah,
back
yeah,
there.
that's
and,
Actually, if you hear Sully, the guy that landed on the
Amazing.
river, he's
Amazing.
like that.
Yeah.
Like, yeah, we're gonna have to ring it
I
down.
think
on the river.
they have to teach them that because
do.
that's where people are so apprehensive is when they're in the plane.
My favorite part about that is he's like, yeah, we'll be in the river, and the guy he's like, say again, we'll be in the Hudson, Roger out, and like the plane, it's like real time. You're watching the video, and he's just like, yeah, we're in the river,
That's oh man.
What?
And by controlling his
Badass.
voice, in order to control his voice, he's got to control his breathing, he's got to control his temper, he's got to control his emotions, and so that's what I do in those situations. And I'll tell you what, if I'm not in a situation where I need to talk, I'll just talk to myself. Be like, okay.
Cactus 15.9, turn left lane 270.
This is Cactus 1539. Hit birds. We've lost thrust on both engines. Returning back towards LaGuardia.
Okay, you need to return to LaGuardia. Turn left heading up 220.
220.
Tower, stop your departures. Got emergency returning. It's 1529. He bird strike. He lost all engine. He lost the thrust in the engines. He's returning immediately.
Cactus 1529, which engines?
He lost thrust in both engines, he said.
Got it.
Cactus 1529. We can get it for you. Do you want to try to land 1013?
We're unable. We may end up in the Hudson.
Showing 2760, turn left 070.
070, showing 2760.
Hi, Cactus 15.9. It's going to be left traffic to runway 31.
Unable.
Okay, what do you need to land? Cactus 15.9. Runway 4 is available if you want to make left traffic to runway 4.
I'm not sure we can make any runway. What's over to our right? Anything in New Jersey? Maybe Teterboro?
Okay, yeah, off your right side is Teterboro Airport. Do you want to try to go to Teterboro?
Yes.
Teterboro, Empire. Actually, LaGuardia departure guy, emergency inbound.
Hey, guys.
Cactus 1529 over the George Washington Bridge. Wants to go to the airport right now.
Going to our airport. Check. Does he need assistance?
Yes, it was a bird strike. Can I get him in for runway 1?
Runway 1, that's good.
Cactus 1529, turn right 280. You can land runway 1 at Teterboro.
We can't do it.
Okay, which runway would you like at Teterboro?
We're going to be in the Hudson.
At this point, we elect to do an anterior vitrectomy. We place the vitrectomy tip posterior to the posterior capsule to pull any vitreous that may be in the anterior chamber posteriorly and to remove excess viscoelastic and any vitreous that may be present. The patient is very calm at this stage. He's expressed no concern. We're just speaking in a normal tone of voice in the operating room. We complete the vitrectomy and then consider if we can place the symphony lens into the capsular bag. It looks like we have some capsular support from 6 o'clock to 9 o'clock and capsular support from 10 o'clock to 3 o'clock that would potentially serve as an adequate platform for placement of the haptics of the implant. So we infuse viscoelastic to expand the capsular bag leaflets to obtain a better understanding of how much posterior capsular support we might have to hold a one-piece acrylic lens in the bag. Ultimately, we insert the Symphony implant that we originally planned to place without any power change. And we place it into the capsular bag. We insert the leading haptic into the equator of the bag at the 12 o'clock position, and then we use a collar button inserted through another side port incision to gently place the trailing haptic into the equator of the bag located at between 6 and 9 o'clock. And when we're looking at the reflex from the operating room microscope, the center of the IOL seems perfectly aligned with the reflex. We remove the viscoelastic using the anterior vitrectomy probe. So ultimately, at the end of this case, we have a perfectly centered symphony implant. This case took about 41 minutes from start to finish, but by applying the principles of, number one, early identification of problems and learning pattern recognition so we can stop, relax, assess the situation, and then move forward with an alternate plan, we're able to safely help this patient achieve his visual goal. Additionally, the principle of luck is where preparation meets opportunity, and by learning from a lifetime of mistakes and evolving, we were able to apply lessons learned to create our own luck of sorts to salvage a potentially very difficult situation for this patient. And lastly, knowing that adversity does not build character, it reveals character, we realize that in times of chaos, effective leadership is so important in controlling your emotions, maintaining your composure, and moving forward carefully and methodically to achieve the mission objective. So here we see the patient's eye on postoperative day number 1. His vision is normal for 1 day after surgery. The implant is perfectly centered in the visual axis. Most importantly, he is happy with his near and far vision and is comfortable. He went to work as usual today and is seeing well. So ultimately, we have a happy patient, happy staff, and a happy doctor, which is our ultimate goal each day. Thank you for your time and attention. Have a wonderful day.